Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we'll talk about referrals to the Neuro ophthalmology clinic and the NOS or Not Otherwise Specified clinic. I would really encourage you to watch the first episode in this series, which covers the generic information that we'd include in any ophthalmology referral, and that will underpin all the talks in this series. Please remember that this is how I would process a referral to the NOS, Not Otherwise Specified clinic, and you must of course use your own professional judgment and follow any local and national policies and guidelines that are in effect. If you're unsure, seek professional advice. Let's drill down a bit into what goes on in these clinics. Starting with Not Otherwise Specified, this is a general ophthalmology clinic, and typically the referrals that are sent there would be for pathology that doesn't neatly fit into any other subspeciality. So it may be a vague symptom like discomfort in a white eye, for example. Or it could be a referral with multiple pathologies, but none of them are particularly acute, or none of them particularly jump out as a priority. In a case of, let's say, blepharitis and wet AMD, it's pretty easy. The wet AMD is going to be referred and the blepharitis will take a back seat. But sometimes you can have a number of sort of grumbling conditions that don't particularly shout to a certain subspeciality. And these patients often need what's been described as a bit of a sort out, which I think is quite nicely illustrated by these two images. Moving on to neuro ophthalmology. So neuro ophthalmology is all about the interaction between the eyes, the brain and the nerves. And you'll often find, if you look at your GOS 18, that there isn't a dedicated tick box for neuro ophthalmology. And in a lot of trusts, neuro ophthalmology falls under Not Otherwise Specified. So we're looking generally at optic nerve disease, visual pathway disease, pupil disorders and acute cranial nerve palsies. And you'll see here's some examples of the types of conditions that may be detected in these cases. A lot of these are acute or at the very least urgent. So let's have a look at the types of cases we wouldn't send to the neuro ophthalmology clinic. Well, non-specific field defects, unless they're altitudinal, quadrantinopic, hemianopic, they may well go to the Not Otherwise Specified clinic, assuming that the optometrist has gone ahead and repeated that and shown that it's a reliable but non-specific field defect. Glaucomatous discs, that's obvious enough, that's glaucoma clinic, and squint and orthoptics of course goes to that clinic. Neurology cases, so for example a patient with headaches and a normal ocular examination, there's not much point in sending them to a neuro-ophthalmologist. You're better off sending them to either the GP or asking the GP to arrange for them to see a neurologist. And emergency and acute cases, which a good number of these are, things like a painful Horner syndrome, third nerve palsy, temporal arteritis, you're not going to be referring them to the neuro ophthalmology clinic, you're going to be referring them as an emergency or a rapid access acute case. So for the context of this talk, I'm not focusing on those types of conditions so much. First, I'll talk a bit about Not Otherwise Specified, and we'll focus on the basics. As usual, a description of the symptoms. When did it start? How often does it happen? How long does it last? How severe is it? Is it interfering with quality of life? Are there any aggravating or relieving factors? What are the signs? Any relevant medical history, including medications, personal ocular history, and imaging, fundus photo OCT. Because these are not otherwise specified, which is in itself quite generic, then the points I'm raising here are also quite generic. A few things to avoid. Lengthy, wordy referrals, paragraphs of text are not so helpful to those who are reading them. And any findings that are unrelated to your concerns, try to not complicate matters with those. So you want a focused, targeted referral highlighting what you believe to be relevant clinical findings. Now let's move on to the basics in a neuro ophthalmology referral. Neuro ophthalmology is a big subject, so these are just some general principles. As usual, the symptoms. But specifically in the context of neuro ophthalmology, you might want to comment on headaches, diplopia, and any transient loss of vision. You then want to assess and record your optic nerve function. So that's your visual acuity. Monocular colour vision is extremely helpful, red desaturation. And in terms of pupils, if there's anisocoria, which is the larger one, and is there an RAPD? So you're commenting on the efferent and the afferent pathways. Visual field tests also helpful, and motility, again in the context of neurological testing. Describe the disc. Is it pale or pink, and is it swollen or not? And imaging, fundus photos, and we'll come on to OCT as an upgrade. I'm not going to talk about upgrading NOS referrals because it is such a vague and generic area, but we can talk about upgrading our neuro ophthalmology referrals once we've got the basics right. So starting off with symptoms, we can put a bit more meat on the bones here. So those three areas I mentioned, headaches, diplopia and transient loss of vision. So in the context of headaches, worse on waking, worse on bending, any nausea, any tinnitus, so these things are pointing towards neurological dysfunction. The usual questions about diplopia, and I've covered that in the talk on the adult squint and ocular motility referrals. And transient loss of vision, so which aspect of the vision is affected? Is it total visual loss, hemispheric, upper, lower? Any headaches associated with it? Jaw claudication and particularly scalp tenderness are really important to record to exclude giant cell arteritis. And other patients at an increased risk of embolus or stroke. If you have a patient with anisocoria, was it noticed by the patient or was it noticed by somebody else? Much more likely to be a new finding if the patient notices it. Is it more marked in the light or in the dark? And the lid position can really help with reducing the index of suspicion. If you have a possible swollen disc, you will have all heard the talks on this, but record the presence or absence of spontaneous venous pulsation. Are there any disc hemorrhages? How's the BMI? Has there been a recent weight gain? Or interestingly, recent weight loss can also be relevant. And to measure their blood pressure to help to exclude malignant hypertension. Imaging wise, I touched on OCT in the last slide, and if you're concerned about discs, then you're going to want to do a volumetric and B scan of the disc to see it in section, and the circumpapillary retinal nerve fibre layer. And disc autofluorescence can be helpful in the context of potentially swollen discs to help to exclude disc drusen. Thank you for watching this presentation on neuro ophthalmology and NOS referrals. This concludes the Ophthalmic Referral series, and I'd like to take the opportunity to thank you for your interest and your support.